It's not a real long PowerPoint. I'll give you enough time to go with it. Okay. Otherwise, I gave the handouts the other day. All right, lab and diagnostic testing for asthma specifically. And really, all the COPDs, we do pulmonary function testing. That's this. Remember, pulmonary function testing is the big machine. You go to the respiratory lab, usually. They put a little clippy thing on your nose, you breathe into this machine, and it measures volume. Volume expired, flow, your lung volume. So that can help diagnose this. The thing is that pulmonary function tests are oftentimes normal in between attacks. So sometimes we use it to diagnose. Sometimes we use it if you're getting worse, or if the treatment we're doing, we want to see if it's working. So we use it for a variety of reasons with asthma. Remember the rules. You can't take bronchodilators before, because we want to see what you look like. Then they give a bronchodilator, and then they retest. Allergy testing, because allergens are so related to that, if we think that's part of your trigger, they might do the skin testing or the RAS, which is blood testing. The other big thing they do is a diary of symptoms. You know, when do you cough? Do you cough in the morning, in the evening? Do you cough after you touch the dog? Food? Do a symptom diary. Chest x-ray. Chest x-ray is not that helpful. We wouldn't use it to say, yes, you have asthma. But if you come in with an attack, we might use it to make sure you don't have a complication, or you don't have a pneumonia, a pneumothorax, something like that. It's not that it's going to diagnose asthma. So they might do it, but the only thing it's going to show is hyperinflation of the lungs if you're having an attack. We rarely ever would do a sputum culture for asthma. So even though they've got increased mucus production, and even though a infection of some sort have triggered an attack, there's just really no point in doing a sputum culture. Now the peak flow, and I mentioned this before, we're going to cover it again. This is kind of the first way to introduce it. Peak flow is used to manage more than anything else asthma, but it can also help us judge severity of an attack. So we'll do it to see where you are, but it doesn't tell us a lot. So let me explain what it does and why you use it. The peak flow is usually an upright device like this with a mouthpiece. It's often just kind of open. And it's a lot like incentive spirometer. You know, incentive spirometer has the little things. This has the little markings, and then as you blow into it, you don't inhale, you exhale into it. It pushes a little marker up, and it basically tells your lung volume. And so this is a great way to measure how you're doing, because a lot of times you're not really having any external symptoms, but you're about to go into an asthma attack. And if you do peak flows every day, your peak flow will start to decline before you actually have an attack, before you actually have symptoms. So this, when you watch your peak flow decline, you have things you're supposed to do to prevent you from actually having a full-blown attack. Because can you die from asthma? Absolutely. If we can't get that airway open, you can die from that. So we don't want you to have an attack because it's dangerous. So using peak flows prevents attacks, tells us what's coming. So what you do with the peak flow is you take a big breath in, and then you put this into your mouth and you go as hard as you can. We tell them, act like you're blowing out a birthday candle in one blow. So it's really important when you test, they want to know these things. You do not inhale into it. You blow out as hard as you can. You have to get your normal. So generally it's by height and weight that we say most people's lung volume is this. But ultimately we want your normal. So when you're having an asthma attack, it's not a good time for us to figure out your normal. So let's say you've never had it before, but you have an asthma attack, and now after it's all done, we want to manage you. We're going to send you home with a peak flow and a little notebook to track your peak flows. And every morning and every evening you're going to do a peak flow. And the way you do it, and I'll cover this on another slide with the details, so just hear it down and you'll see it written in there. You do 3 blows, 3 times, as hard as you can. You push the little, you you write that down for the morning. Then this evening, you do it again. 3 blows, the highest number. Tomorrow, in the morning, 3 blows, highest number. And you do that for several days, maybe even a week or so at first to get your normal. Then we find out maybe that my normal is 450 because I'm over my asthma attack. I've been doing this for a week. That's where I normally am, is 450. So then what they do is they'll put a little sticker on here that has a green zone, a yellow zone, and a red zone. And you put your green zone at 450, and then your sticker will show you when you're in the others. And so every day when you do your peak flow, if you do your 3 blows and all of them are in the yellow zone, your best ones in the yellow, you have certain things you're going to do based on that. So it's really cool, simple, easy technology. I mean, it's just a plastic device. There's nothing else to it. So we'll cover it again in a second, but it's not really used to diagnose, but we will use it if we can in the hospital. Again, you may not be able to take a deep enough breath to use that peak flow, but as you get better, then you use it. All right, so treatment. You absolutely have to know asthma treatment. Everybody who's having an asthma attack needs a short-acting bronchodilator. So we'll talk about SABAs here in a second, but it's a short-acting bronchodilator, like albuterol or Zopanex. They're rapid, short-acting bronchodilators. First thing, so we like to test with you are having an asthma attack. The doctor has ordered all of these things. Which do you do first? It will always be the bronchodilator, short-acting bronchodilator. If you have persistent asthma, so you have attacks periodically, you need daily therapy, and that will include a controller medicine. The controller is an inhaled corticosteroid, ICS inhaled corticosteroid, that you're going to take every day. We call it maintenance. It's prevention from having an attack, is the ICS. SABAs are what we call rescues. When you have an attack or you have episodes of wheezing, you use a rescue inhaler, and that's the short-acting bronchodilators. So anybody with persistent asthma should be on an ICS, an inhaled corticosteroid, every single day, regardless of their symptoms, and they are not used as treatment for an attack. We give it to them, but it's not treatment for the attack itself. If you have a mild to a moderate exacerbation, we'll cover, that's the peak flow. Well, it probably shouldn't say 50%. It should say 50 to 80%. So a mild to moderate is usually 58% of your normal peak flow. Then what we give them is the short-acting bronchodilator every 20 minutes, 3 times in a row. They can do this at home, or they come into the clinic, and this is what we're going to do, or they come to ER, and that's what we're going to do. The bronchodilator every 20 minutes. Then we may put them on oral corticosteroids. That would be like a dose pack, a short term. And if their stats were low, we would give them oxygen. That's what we do for a mild to moderate exacerbation. That's usually enough to get them back to normal, and then we're going to do some maintenance things to keep them at normal. If they have a severe exacerbation, so their peak flow is less than 50%, they're going to need to come to the ER, and they may have been trying stuff at home. What we do is a continuous short-acting bronchodilator, and that's going to be by a nebulizer. It's going to be continuous, not turned off, and we add atropine to that, which is a steroid. And then we are going to also add either oral or IV steroids to decrease inflammation, and that's going to be every 4 to 6 hours. And then it could get bad enough that you need an arterial line where we're doing ABGs constantly, or intubation. We have to actually take over your breathing for you. Or, really cool, is Heliox. Heliox is a mix of helium and oxygen. And we do this in peds, they're doing it in adults a little bit. Heliox does 2 things for you. Helium bronchodilates, so it will help the lungs with the bronchodilation, but helium is a lighter gas air than oxygen. And so it will carry oxygen into those very narrow spaces. So if our asthmatic, we call them wheezers, if our wheezer is and their O2 sats are staying down and we can't get them up and we don't have them opened up yet, we'll put them on heliox, and that will oftentimes allow us to oxygenate them without intubating them. It's awesome technology now.
Does it make their voice sound like they?
I don't think so. They were just using it when I left, so I haven't seen it used enough. I don't think so.
Because they just threw.
Yeah, you put a mask, like you do everything.
I think one of the nurses was saying something about that at the long-term care facility that we're at. So would you use it in elderly?
I don't.
She was saying something about helium, not helium.
I think you would use them together with oxygen. We see it sometimes in ARDS patients. You wouldn't see them in long-term care. Maybe with pulmonary edema, they would do it. Probably not straight helium. It would be helium and oxygen, helium. I don't know what they're doing in the elderly with it. I'll have to look it up. Now, a couple other rules. We do not give theophylline. You guys don't necessarily need to know a lot about theophylline. We'll talk about a little with COPD patients. Theophylline opens airways, and we used to give it a lot in the old days, 20 years ago, but it's very toxic. You have to monitor blood levels, and patients get toxic on it easily, and they'll get nausea, vomiting. So theophylline is not a first-line treatment at all. Mucolytics break out mucus. I mentioned, even though they have increased mucus production, we do not give them mucolytics. When we fix the bronchodilation, the bronchoconstriction problem, the mucus will take care of itself. Sedatives, why would we not give an asthmatic a sedative? Yeah, they increase their respiratory rate and their effort, their ability, and that would be a bad thing. Antibiotics, pretty uncommon, although, again, bacterial infections can trigger an asthmatic to have an attack. So in that case, we would give it, but in terms of just treatment for asthma, that's not for the treatment. It's only if they have a concurrent infection. Chest percussion, we also wouldn't do. That's that pounding on the back to loosen up mucus. That would just really be too stressful for an asthmatic. Again, opening their airway is what will take care of the mucus problem. Alright, so this is just showing you kind of the drugs at a glance. So in an acute attack, you give bronchodilators and anti-inflammatories. Bronchodilators are most important thing to do, and we tend to give the beta-adrenergic agonist, that's Proventil, Alupid. Well, they'll end with albuterol, metoprolol, levoalbuterol. Epinephrine, we rarely use. Epi is reserved for anaphylaxis, which could be asthma symptoms, but it's not a typical treatment for asthma. Anti-inflammatories, we do give corticosteroids in an acute attack. We typically give prednisone orally. We will start inhaled corticosteroids in an acute attack, but it's because inhaled corticosteroids take time to work, 3 to 5 days. So the reason we start them in an attack is not really for the attack itself, it's to get them on board so we have a nice maintenance going when we are done with this attack. So kind of like you think about Coumadin and heparin, it's kind of that idea. It takes time. Their corticosteroids are maintenance. They are not your primary thing. Bronchodilators are. Now here's the chronic management. Bronchodilators, but then we expand our bronchodilators and our anti-inflammatories. So the bronchodilators, we have different types. We also have short-acting and long-acting. And then our anti-inflammatories, we have inhaled anti-inflammatories. We have what are called mast cell stabilizers, and then we have leukotriene modifiers. I'm going to mention all of those in detail. Again, pharm, you should have at least been introduced to all this stuff. But it is really important, and so I do test on it. I test on everything on the drugs in the next couple of slides. So I'm going to help you out with those. Anti-inflammatory. Maintenance. Corticosteroids, leukotriene modifiers, and these anti-IgEs. Corticosteroids, Flovent, Pulmicort, there are two most common ones. Again, prevention only, maintenance, not rescue. They take a couple of weeks to work. They do not have systemic problems like oral corticosteroids, the inhaled stuff. That's why we like them. The inhaled corticosteroids go just to the lungs. And so they have all their effects in the lungs where we want them to. They really don't have any bad effects in the lungs. Where they can have a bad effect is in your mouth. So when you use an inhaled corticosteroid, oftentimes you want to use a spacer and rinse your mouth. So you just use it like you do any inhaler, which we'll talk about in a second, and then you just swish and spit with water. Spit it out a couple of times. Otherwise, you will get thrush in your mouth from these steroids. That's about the biggest side effect you get from these. Sometimes we do give oral corticosteroids, but it'll be a short burst, not usually something all the time. We prefer the inhaled because they're so much better for you. The leukotriene modifiers, the primary one is singular or accolade. These are pills, not inhalers, they're tablets. And they are, again, for prevention. And then this is a new category, anti-IgE. Xolair is the drug. This is actually sub-Q every 2 to 4 weeks. And it's for people who have severe asthma. I'm not testing on that. That's actually brand new to me, this drug. But it does have a risk of anaphylaxis. What that means is you would have to go to the doctor's office to get it, where they have emergency equipment, and then you would stay 20 minutes after getting it, and then go home. So these are people that are having trouble managing their asthma. They're in for attacks a lot, and that's risky, so they're going to try to manage it more aggressively. All right, the bronchodilators. Again, these are our first-line treatment for rescue, but we do have short-acting beta-adrenergic agonists and long-acting beta-adrenergic agonists. Here's the thing. Long-acting are not for rescue. Long-acting stay in your body for 12 hours. They're not going to work immediately. They're for maintenance. The short-acting, everybody should have one that has asthma. That is a rescue drug. So that's albuterol, Maxair, anything that has albuterol at the end of it is going to be a short-acting. They work immediately. If you're having trouble breathing, you use that, solve it, and it works right then. What side effect does it have? Increased heart rate. What else? Did you say diaphoresis? No? It makes you shake. This is fully expected. Your hands get real shaky, you get tremor, you feel kind of shaky all over. It raises your heart rate. Like in kids, it can raise their heart rate to 200. That's a problem in adults. In kids, we don't really care. No, the short acting. You know that we're a little long and it's really short. So it raises your heart rate, it makes you shaky. That's expected. You tend to feel a little anxious with them. That's all expected. It is potentially a problem if you have a cardiac patient. So we don't have many cardiac patients in peds, so we don't really care if their heart rate gets really high because we know it'll go in. But in adults, it's a problem. Because if they have cardiac disease too, their body can't handle that stress. So there are some alternatives for them. But this is really expected. It's not something we're concerned about with the short-acting. If you use them too often, they can cause bronchospasm. They can actually cause problems. So it's really important. We talked about this the other day, last week I think, where you should ask, how do they use their inhaler? And ask them to demonstrate it, but also how often. If they're using it every 2 hours all the time, they're probably making their problem worse instead of better, or they're totally uncontrolled. So we always want to ask how often you use it. You really should not be on a SABA routinely. You shouldn't be taking that every 4 or 6 hours unless you are taking it with a corticosteroid. Because if you're needing it every 4 to 6 hours, you're not controlling that's what that means, why it should be used in combination. And so our goal really is that you always have a SAVA with you, but you never have to use it. That would be our goal. If we have you so well controlled that you don't need a rescue. So that's where we're headed. These beta agonists that are long acting, Ceravent, Oradil, never should be used by themselves. If you're on a long acting, that means you're not well controlled and you must be on a corticosteroid. If you're not being managed appropriately. So that's what we mean by never use as monotherapy. So this is just a repeat. Only use if they're taking an ICS with it. You do not use them as a rescue because it's an every 12-hour thing. And in emergency, you had nothing else you could, I guess. But generally, they don't work fast like the short-acting ones do, and so they're not a rescue. We have a lot of combos. Advair, Symbicort, those are combination. It's a long-acting with a steroid, so they get it together, so they only have to have one inhaler, one device.
So if a patient did have controlled asthma for say like 2 years, would you still make them carry a SAVA and still refill it?
Yes. The SAVA they should. Now, I mean, there's periods where you go, you never have an attack, and so you don't maybe have it with you, but if you start to have it again, because anytime you get sick, you're likely to need it. So it's really better for them to always have it.
So even if they haven't used it for 2 years, the doctor's still going to keep refilling it?
I mean, sometimes people grow out of asthma, and then, but the first time they have an attack, they've got nothing. So they're going to end up having to go to the clinic at that point. So, and it kind of depends on if they really did grow out of it. All right, other bronchodilators that we have. Methylxanthine, that's that theophylline or aminophylline. Again, these are very easy to get toxic on, so we don't use them as a first-line treatment. If things aren't working, that we might add them, or sometimes we use them in the hospital under very controlled situations. We can give it, like an IV infusion of it if we need to. So you have to monitor blood levels. You have to watch for toxicity in those. The anticholinergics, Atrovent is the most common one. These don't work as well as those beta-adrenergic agonists, but if you have cardiac disease and you can't use those SAVAs because your heart rate can't tolerate being raised like that, these are a good alternative. So oftentimes we use these with COPD patients that have heart disease too, and they can't tolerate the albuterol because it raises heart rate too much, so we give them the Atrovent. All of these things, well, most of these can be nebulized too. We can put them in a machine instead of just an inhaler. All right, how to use them. This will definitely be tested over. Everything on this slide, this you learned in fundamentals, and maybe, I don't know if you learned drug administration in pharm, or is that in fundamentals? Fundamentals. So you already learned this. This is a reminder. So we have MDIs, we have DPIs. They are different in how we teach. We like to test you to see if you know the difference. So the meter dose inhalers, that's your typical inhaler like this. A DPI, a dry powder inhaler, doesn't always look like this, but this is a common one. Advair is one. Sometimes you actually put a pill in and then it crushes it. The key thing is it is dry powder inside, so you can't get anything wet around it. You don't want to breathe into it, things like that you could get away with an MDI. And they are used differently. So with the MDI, you can add a spacer. Spacers look like that, or there's collapsible ones. They look like a little accordion, and then you just hold it open so they're easier to transport. They just provide space between your mouth and the inhaler itself. Because the problem with MDIs are you have to coordinate inspiration with the pushing, and the breath has to be coordinated. And we really believe nobody can do that very well, so we really prefer everybody use a spacer. But you have to push it and breathe in at the very same time, or it doesn't work as well as it should. It gets on your teeth, your tongue, your mouth, instead of where it should be. So spacers take that away. If you put a spacer on, you push it, and then you inhale You do shake the MDIs before use. You always shake it like this, then you go to use it. You have to clean them. They can get clogged up. And so what you do is you take out the center part that's, let's see if I have it. The little canister part you take out. And then you just can rinse it with water because it gets little crusties in it. This is an old wives' tale. We used to do this. We used to tell people to float in their water, and if they floated, then it was empty, I guess. I don't know. It's not the way to do it. They have a propellant in them, and so it doesn't do any good. It doesn't do any good to listen and see if it has anything, because you may just be hearing the propellant. And it doesn't do any good to float it to see if it's full or not. In fact, the new ones have numbers on the back, which is really nice. They have 200 uses usually, and they count down every time you do a puff, so that you know when you're out. Because the problem with the old ones are you don't really know when you're out, because you can't shake them, you can't lay them. There's no way to really tell unless you're tracking how often you use it. So they've kind of taken care of that with numbers. I mentioned that. Okay, so here's how it works. You shake it, you breathe out, you put it in your mouth, you press down at the very same time you inhale. So you go. 10 seconds. That's how we teach kids. We teach them to do it with their fingers. So 10 seconds is how long you hold your breath. So you just keep your lips on that, or you close your mouth right after you've inhaled it. The idea is we want to let that go on down into the lungs. So that's how MDIs work. You hold your breath for 10 seconds. You inhale at the same time you push the button, unless you're using a spacer. Oops, shake before using. All right, the DPIs, much easier to use than an MDI. There's no spacer, there's no shaking, and it does have numbers on it. It shows the number of doses left. So some of them have a slider mechanism. Again, some have the pill and you twist. When you move that slider to release the powder, then it changes numbers. You don't have to coordinate anything with inhalation, because as you take a slow breath in, that powder gets inhaled. The big difference is deep and quick, I said slow, is a deep and quick breath with the powder, and it's more a slow breath and hold your breath with the MDI. Deep and quick, but you still do the 10 seconds of holding your breath after the DPI. You need to keep it away from humidity. Don't breathe into it. So it has a little, it's not a mouthpiece thing as much as a little opening. It looks kind of fun, like you could blow in it, like it would whistle. But if you blow in it, you actually get moisture in there, and that can clog up with the powder. So you don't want to store it in the bathroom. You want it away from humidity. So that's the DPI versus MDI. Everybody got it? It should have been reviewed. Now here's nebulizers. There's with a mouthpiece. Here is with a mask. The nebulizers just convert the drug solution into a mist. So you have a little vial usually, and it's usually plastic. You squirt it in to the machine. It's usually mixed with saline. And then you turn the machine on, and it just blows smoke out. So it's converting that liquid into a mist. It doesn't have to be oxygen. At the hospital we use oxygen, but at home these devices, the home devices, it's just compressed air. And so once you put the medicine into a little cap that sits on the bottom there, and it sits up there. You drop it into the cap, you turn the machine on, and it just blows it in. And they just breathe normally. Don't breathe extra deep, you just breathe completely normally. And then smoke goes in and out as you take a breath in and out. Yeah.
If a patient is on oxygen, would you keep that on while they're getting?
Yeah, if they're on a mask like this on oxygen, it just connects at the bottom of the mask. The nasal cannula, we'll put a mask on them if it's a kid, or we'll leave the nasal cannula and do this. With kids, we call it a pea spot, because they breathe in the smoke and then they blow it out, so they can see the smoke go in and out, and it helps them kind of see they're doing it right. But yeah, you can leave them on the nasal cannula and then just have that too. There's controversy over which is better. In the hospital, we do these most of the time, and then when we're getting them ready ready to go home, we'll switch them to an inhaler to make sure they're doing it right. But we do the nubs usually when they're in distress. In theory, and for me personally, this is true also. I can't always breathe deep enough to get a good puff in with my nebulizer, with my inhaler. But with a nebulizer, it takes about 15 minutes to give the dose. So you're getting that warm, well, it's not warm, but you're getting moist air in during that whole time. And you're having to sit still for 15 minutes. And it's a finer mist, so the idea is it can go in a little bit deeper. But it takes about 15 minutes to give these treatments.
Is that for rescue, or is it just like that if you do your...
You actually, like kids, especially young kids, infants, or even 2s and 3s, will do this instead of inhalers because they can't coordinate an inhaler effort. Although we have masks for inhalers, so you have a spacer that has a mask on it, and you just make a seal, and you do the same thing. But we do oftentimes do it through this because it's almost easier at home. So usually in the hospital, it's for rescue. These are going to have the same side effects as we talked about, making your hands shaky. But do you think they're going to make them cough? Why would they make them cough?
Because you're taking a deep breath.
Taking deep breaths, and it's a bronchodilator, usually, that we're giving, so we're opening your airway. So once we get your airway open, you tend to cough and get mucus out. That's really the whole point. So it's not unusual for them to start coughing once we give these treatments because we're opening their airway.
Are the drugs that you give for like pneumonia and asthma the same drug? Just to
Yes.
bronchodilate them?
Yes, we're giving bronchodilators. Sometimes we give steroids this way too, sometimes a combination. In the hospital too, respiratory gives these. You guys don't give them, you don't monitor them. In inhalers, it varies. Some hospitals, I've seen respiratory do it, others, the nurses do the inhalers. But yeah, in pneumonia, oftentimes you're giving it to just kind of help them get past this, and they may or may not truly have asthma. They're just trying to get past that inflammatory process. Yep. All right. Things that we can do to prevent asthma or help them stay healthy. Stay away from those triggers. Use dust covers on mattresses because dust is a trigger. Cold air is a trigger. So wearing a scarf, you shouldn't have to memorize any of this. It should all make sense to you. Avoid aspirin or NSAIDs if they're hypersensitive to them. Get prompt treatment of upper respiratory infections of any kind, sinusitis, because that will trigger an asthma attack in people that already have asthma. If they get any kind of upper respiratory infection, it usually leads to an attack. So the sooner they can get treated, the less likely they'll get an attack. Lots of fluid intake, good nutrition, rest, all just plain old Jane things. Acute, we already said, the first thing is that short-acting beta-adrenergic agonist. So that short-acting bronchodilator. We already talked about this. Oftentimes your wheezing gets worse as the airways get open, and so that's a good sign that we're making progress. And then a way you can slow them down besides just saying breathe with me is you can teach them to pursed lip breathe. So you know how to do pursed lip breathing. Get them to try to breathe like they're breathing through a straw, not puff their cheeks out, but just and try and it prolongs expiration, which will slow your breathing down. So pursed lip breathing is a good thing for an asthmatic to do also. How do we know that our SABA worked in asthma attack?
Thanks, zero.
So respiratory rate might go down. What did you say?
Symptoms there.
Well, but we said you're better if your wheezing actually gets worse. So it's not your breath sounds. It's more work of breathing, respiratory rate, O2 sat. That's how you know they're better, not their breath sounds. Because again, their breath sounds tend to sound worse before they sound better because we're now moving air. Ambulatory home care things. Good nutrition, exercise, staying symptom free. But this is what I want you to know here is their peak flow daily. So again, best of 3 flows every single day, not an average. They blow out. Oh, I said blow into the device or blow out, however gives her her yellow and red zone. Now, as kids grow, we have to adjust that because it should change. Their lung capacity should get better. But here's what you have to know for the test. Green, that is 80 to 100% of your personal best. If you're in the green zone, you don't do anything different than you've done before. You take whatever meds you always take, you do as much exercise as you've always done, you do everything exactly the same. It's great. If you are in the yellow zone, which is 50 to 80% of your personal best, if you're in the yellow zone, you have to be more vigilant. And what you're going to do is take your rescue inhaler every 4 hours usually, round the clock. Regardless of how you feel, all day you're going to take it. Because oftentimes, this is showing a change before you feel it. You might not feel like you need it, but we know if you do it, you're going to prevent an asthma attack from occurring. So you can still do what you need to do. You just need to add your rescue regularly around the clock. Red, if you're in the red zone, you need to take your rescue inhaler and then you need to either go to the doctor's office or to the emergency room. That, you shouldn't be going to the gym, you shouldn't be running, you shouldn't be exercising. At the red zone, you are imminently having an asthma attack, even if you don't feel like it. So you take your rescue inhaler and you go to the doctor. Make sense? Alright, COPD, chronic obstructive pulmonary disease. This is persistent airflow obstruction, slowly progressive. We mentioned that. It is not reversible. There is no cure, but we can slow the progression and manage the symptoms. Smoking, the biggest risk factor. It's not the only one. People with COPD may have never smoked a day in their life. But if they smoke, they're going to make their disease worse. They're going to make it progress faster and cause more damage. So it may have led to it, and it's certainly going to keep it worse. Chronic bronchitis versus emphysema. So look at the difference. Chronic bronchitis is a chronic cough, and this is kind of confusing, but just glance at it. For 3 months in each of 2 consecutive years, in whom no other case, we can't define it. So you didn't have an obvious reason to have it, like you got pneumonia or you had the flu or whatever. You just chronically get this coughing episode over and over again is how we get to this. This is an inflammation of the bronchi, usually because you've been exposed to irritants, and you are hyper-responsive to that than other people. It does affect airways, not the alveoli. That's the definer between this and emphysema. Now again, people could have combinations of both of these. They could have both emphysema and chronic bronchitis. They get lots of thick mucus, decreased gas exchange, so their sats will be lower, and thickening damage of the airways, so the airways become narrowed when that happens. Emphysema is a problem out the alveoli. So that's a big definer. The alveoli are permanently, oddly enlarged. So some of the alveoli are just destroyed and not usable. And where's our gas exchange occur? In the alveoli. So it's a problem when they're not working right. So some of them are damaged. Some of them are just big and floppy. And so they trap air in them. When the air gets trapped, the lungs hyperinflate. When our lungs are hyperinflated all the time, we get barrel chest. So if you are not in your 80s and you have barrel chest, you probably have COPD and more likely emphysema. If you're in your just get worse and worse.
So chronic bronchitis turns into emphysema?
No, they're two different diseases within COPD.
And you can't have them.
You can have them
At the same
both.
time?
You can. Yep. So COPD encompasses chronic bronchitis and emphysema, not asthma. However, people could have all three. They get chronic bronchitis, emphysema, and asthma, which is second.
So people with COPD, they get pneumonia more? Is that the infection later?
Yeah, they can get pneumonia more, and any infection, like if they get sinusitis or an upper respiratory infection, tends to lead to pneumonia and an exacerbation. Any of those things will lead to an exacerbation of their symptoms because they don't have the reserves to counteract that.
So is the reason why we don't want to put them on like too much oxygen because of CO2 that
Yeah, so what happens is because they have that increased work of breathing, and that's really true for both of them, eventually, they retain more CO2. So when you first start to retain CO2, your body says, oh, your CO2 is high, I need to breathe faster to get that out, and your body adjusts to that. If you chronically have a high CO2, the body finally says, well, I guess this is how it's going to be. And so now your body has learned to ignore that CO2 drive, and now it only responds to a hypoxia drive. So the reason we don't want to just crank them up is because of that hypoxia drive. That doesn't mean we want them hypoxic in the 70s or even the 80s. Generally, the rule is if you can keep them at 90%, you don't aim to be much above 90%, you're going to be safe. So oftentimes they come into exacerbations, they're going to be 85, 86, and you do need a turnaround. You just don't crank them. You don't throw a mask on at 10 liters. You just turn them up to 4 liters nasal cans instead of the 3 they were already on, or the 2 they were already on. So this is all the patho. So you can see how these alveoli do not look normal, and they can get bullous or blebs, and then those blebs can sometimes burst, and then they get a pneumothorax, and they end up with a chest tube. So those things can happen. So this is kind of showing you the patho, and then I have a whole bunch of patho explanation if it helps you understand. There's not so much that we test on patho between the two as more care. Were there any questions on the stay guide about patho? I can't remember. I don't think I really have any true patho questions. I just don't test patho that often. So pay attention to the study guide, I don't think. Cigarette smoking, biggest cause. All the other things, look, these are a lot like what we saw with asthma. Certainly they'll be exacerbated, but here is a genetic component. There's two genetic things with this one. One is we think genetics are what defines which smokers get COPD and which ones don't, because not everybody that smokes gets it. I mean, most of them do, but not all of them. But the bigger one is this: alpha 1 antitrypsin deficiency. The reason this one is so important is because if you're under age 40, like most of you guys, and you have no smoking history, and you have a cough that will not go away, maybe you were treated for asthma and nothing's working, like my student in the other class, she needs to be tested for alpha 1 antitrypsin deficiency because she's prone to get COPD without the usual risk factors. And actually, her mom has it. So it's highly likely she has it, and she needs to be tested. So for you guys, in terms of testing purposes, anyone who doesn't really fit that profile of COPD, who has clear COPD symptoms, that's younger, they need to be tested for that alpha antitrypsin.
Is there something that they can do, like if she goes to get tested, is there like
You know, I don't think so. I think it's that they wouldn't mess around thinking, oh, well, we just want to be on the right antibiotic. Let's try this, let's try this. They'd more distinctly treat her more aggressively. Whereas with anybody else like us, they'd think, well, we just need to have time to get over it. So I think they'd be more aggressive saying, not that I know of. Diagnostic tests, PFTs, those pulmonary Maybe Jesus severe. Chest X-ray doesn't tell us a whole lot. We use it in exacerbation, but it's not diagnostic. There are several questionnaires. I didn't include the name of them because I don't think it really matters, but it's like questionnaires, things you ask, like, do you cough every day? Do you cough every night? And it starts showing a picture that tells us, oh yeah, that's chronic bronchitis. Any patient that's over 40 with a smoking history that has chronic cough or sputum production or shortness of breath and any risk factor, you gotta assume they have COPD. Even if we can't totally prove it,